Thanks, Matt. I forgot I was on mute. I was on mute, but that's the reality of today's our days right now. The often line is you're on mute.
Yes, it's the new reality of this world we live in. I do it regularly.
Well, let me just give a few highlights of what I uh, watched earlier with your presentation. I particularly like the 3 points when you're appealing the case for community mobilization, because this is really important, not only for the communities, but for NGO workers, CSO workers, and for local government officials to have an appreciation of it. So let me just run it down very quickly. It is a critical enabler. It is a cost-efficient and versatile and deliverable, and it's also ethical and empowering. I'm going back to the ethical part later. Okay. Also, I saw certain terms. It's privileged access, and in our terms, we call it the VIP system. It's my BFF is running this. I can get better access. That's the feeling for communities. You also had this individual outreach model and the multiplier model, which demonstrate the scalability of things. It starts with the individual outreach and one-on-one peer support. And it becomes bigger as community members knows one friend to another. Our networks become bigger, and the services reaches more people. The advantage comes from the level of familiarity, I guess, and the technical knowledge exchange is also there. So, and that's a lot of highlights. So let me just, sum it up. I learned that we can remember things if we do it on trees. So, peer works. Number two, it's adaptable and allowing people to use contexts that is challenging. And lastly, it is the 30% of the global age strategy, that 30% of the HIV response, it's where it should be. But if I may add the last part that particularly piqued my interest is being paid. As a community leader, being paid is actually important. And maybe we could look at it on your video later. Do we have questions from the, or do we have community members on the chat box? Please raise your hand if there is. Maybe we could put you on stage. We could exchange, because that's how community works. It's about exchanges.
Yeah, look, while you're looking, let me just make a comment about working in high-risk situations, because I know that's a real issue here in the Philippines. I think one of the ways that these community networks that I was showing you can work is that they can also be very protective. So one thing that's happened in Spain, for example, is what's called the Cannabis Social Club movement. And here, this is basically groups of friends who would normally have smoked together, coming together to grow. But because they don't let anybody who wasn't one of their friends into the network, it makes it a much safer space to work in. Even in the UK at one point, they estimated maybe 30,000 people were growing and sharing cannabis together within these small friendship clubs that could be protected. Now, they still remain vulnerable to organised crime, robbing them. They still remain vulnerable to police. But I think this model of looking at it's a model that's also been used in Ireland, for example, in different models where there's cell structures. So you make sure that you keep the contact between different groups to a minimum so that you protect the groups from infiltration from outside. And I think it's really sad that we have to talk in this way about community mobilization, but I think it's also really important you build in risk management from the start, because from a personal experience, I learned risk the hard way and made a mistake and got into problems. And that's why I'm now such a champion of the need to do proper risk management and to really manage our safety.
I was about to ask that difficult question, because peer workers are often active drug users. If the community is actually about just drugs, but you also mentioned the context of HIV. Maybe people are expecting if we're talking about harm reduction here. why HIV? And you also mentioned a few words that people who are not involved in the community wouldn't be familiar, because when I was starting, I didn't even know what a key population is. Who are they? And we started with learning that. So if maybe you could, get our audience who are not involved in the community to learn about it. I mean, maybe you could put up more context to it.
Yeah, that's sorry. Yes, apologies for my use of technical languages, but it's
Okay.
good to unpack it because it's as we advocate in the system, it's also good to understand how the global system is using this language. So the term key population means that key populations affected by HIV. So we've seen the transformational role that people living with HIV and their networks have played within the global community. One thing they secured early on was something called the JIPA principle, so the greater involvement of people living with HIV. Now, that has been signed up to by governments and the United Nations, and it has made the HIV sector very unique because in the global law is a commitment to the meaningful participation of people living with HIV. Now, as the global community has then recognized that alongside people living with HIV, there are four populations that constantly are being clearly affected in what's called concentrated or very intense epidemics among particular communities. And this is people who inject drugs, and now also recognize people using stimulants, because we see this key intersection of people often who are smoking in a pipe methamphetamine or crack cocaine. These people are maybe not having a direct drug-related risk, but they are enhancing their sexual risk often through the use of the stimulant drugs. So that's one population, people who inject and more
Youth.
broadly use stimulant drugs. And then men who have sex with men, or gay, bisexual, and men who have sex with men, people who are from trans communities, and then people from sex worker communities. So the four, what's called the four key population networks, the global networks, ours is an international network of people who use drugs, and other networks exist for the other communities, have made this coalition and fought very hard for the recognition that the key populations are in different countries more or less able to take part in the response. And what we've found is in certain countries like the USA, where the gay men's movement is much more integrated, they can help the drug user movement or the sex worker movement, who is less integrated. In a country like Afghanistan, where the drug users have the lead role, they can bring in gay and bisexual men behind them into the engagement where that is far more stigmatized, even than drug use. So I think this has been a key part of the success, is our communities coming together, and like the Peer Works program was both sex workers and drug users taking part together.
Thank you for defining who are our key populations, for our very interested, not involved in the community yet, and we are looking forward to see you being involved in the community. And as in my early experience, and we actually started quite a few years back. There's another term that expands the key population term, that the vulnerable groups. Yeah, that involves women, young people, migrant workers, people. Yes, and these expands the dynamic more. And I feel that it's really important that we know who are vulnerable and who are the key populations, and we understand each other, our intersectionalities, because sometimes people who use drugs are also MSMs, or people who use drugs are also transgenders or sex workers. So, and that is why we have come up with the term persons with multiple risk here. So, and that's the nicest thing about this. We could continue supporting each other, and knowing each other's where each other is coming from, understanding the our ranges of realities. And to those who are to our local audience, we have been using this for the last few days. Ranges of realities, and in our local context is kung saan ka nang gagaling in our yung pinanggagalingan nating magkakaiba, where we're coming from differently, and we have to understand each other's context and our each other's set and setting. Uh, Thank you for telling us highlighting that this is also a health-based issue, not just for drug users, but also for other viruses like HIV. It could also be for TB, right? So there are all other applications to it. Let me just go ahead and read some of the questions. Thank you, Matt, for the amazing presentation. Given the current view of people who use drugs in the country, what are practical ways we who are part of NGO, CSO, government, religious sectors, etc., can help uplift and empower the voices of the community?
Thank you, Rod. I think it's a really important point. I think I think we have to choose the times that we speak privately behind the scenes with people, and the times when we speak publicly and out in the open. The situation in the UK for the last 15 years has been very difficult. We've had governments pushing a very heavy recovery model, undermining harm reduction, and many drug user groups pulled back and worked in our own communities. There was no point in talking to the policymakers and the planners because they were selling us a model that we knew didn't follow the science. So we preferred to spend our time helping our peers in the most local way we could. COVID has changed things. It's allowed us a new dialogue with our government. So we've chosen to come back out again and use this chance as a time to say, thank you, you're now recognising public health again. Let's now have a discussion. The expertise you're looking for never went away. We just stopped working with you. Here it is. We can help you now that you're back in the world of reality again. Try to be a little bit more diplomatic, but that's generally our feeling of where we've been. So how do you apply that to the Philippines? I think you need to think together, what's a safe way to engage drug users at this moment in time? How can you foster community mobilization? Is it about maybe sympathetic religious leaders having private meetings with some drug users so that they can then share that testimony with other people? Is it finding ways of using your human connections with people in your community to help your NGO better understand how it responds to the local community? I think as you build the infrastructure and capacity of drug users, you'll find people who also want to work with you to go further. But I think recognize that this work takes building. It's slow building work. The work I described to you in Afghanistan, it took, that's 20 years of work to go in this journey. So don't be inspired by what you see around you, but don't be hindered by thinking you have to immediately do that. Start with the small steps, build the relationships. I was speaking to a key doctor in the UK who had been pivotal in working with crack users to help the UK understand how to respond to crack cocaine, our big stimulant drug. And she said, look, when I started, I didn't know anything. I knew I needed to know something. I knew I wanted to respond to this community in trouble. So I asked them what they wanted, and then we worked it out together. And I think that willingness to be humble on both sides is a way of allowing this lived and learned experience to come together to create something transformational.
Thank you. I think it's also about the level of trust. And right now, when we mentioned earlier the religious and the government, and or we're also on the context of stigma and discrimination, the key population have their own view of institutionalized stigma, public stigma, and internalized stigma. But if we look at it on the other way, the key populations or the PWUDs doesn't trust the government because they also have a stigma on the government. They don't trust and they don't believe they can help them. It's like I had a conversation before with people from the Department of Health, and they ask if our community says there's an HIV test and there's a form and there are questions. Are you using drugs? And the question is, are they being honest? Are they
Yeah,
being honest on that question? And a lot of people said no. It's because they do not trust it, and that's actually a stigma on the on government organization and the whole government itself. I think we had to appeal also to our community members that there are government that there are mandates of the government that we have to be honest about, because they are tracking these things and we can create better responses. And the stigma is actually all around us. We have to be very aware of about it. And let me just check. How about religious, right? People feels that in our context, in the reproductive health bill, there are people from our religious sectors who are against it before.
yeah,
And now that we are with them and working with them, it's actually a great relationship. And the community doesn't always mean us, people who are in the experience. It's also about building the network and better relationship with these other agencies, because we cannot just work and live alone.
yeah. Well, look, I really agree. I mean, I have difficult relationships around religion, partly because my dad was a Church of England priest and someone who broke every value that he sold, and so I became very distrusting of religion. And then I helped a community of drug users go through 10 years where we had to care for 60 of our friends who died of HIV. And because the hospitals wouldn't look after them and respect their drug use, we worked with community nurses to put buddying teams, community teams. So, and this is before antiretroviral treatment, where people were able to die in a way that respected their choices as drug users. Through that process, we met some grassroots religious leaders from the Italian Catholic Church, a lovely Father Camello. We had local Jewish priests, local Muslim imams coming to care for the drug users who were dying. And then we had an annual memorial service where the drug users came together with this range of different religious leaders. And we even had, because we had a big migrant Italian drug using community, several years later, there were family members who would travel each year to come to the memorial service because they said it was the only time they could mourn their children with honesty and without shame. And I think understanding the spiritual needs of the wider community, and understanding that particularly if we're facing death and health issues, that can be very important. And I think we need to see people and empathize with people who may not be our traditional allies. And I think when we find the right people, they can be remarkable allies because they can help transform people that we might not ever be able to reach.
Thank you, thank you. Let me just go back. How can we handle situation in which community members may have different goals or views on drug use?
Yeah, look, I think this is an important issue, and I think and I was appreciating Andrew's comments in his exploration of how we care for people. And I think partly it's about empathy. And I think we trained our drug user team in motivational interviewing. And actually, it was really helpful to be trained professionally in empathic engagement and how to empower people, how to really listen to people. Because the reality was not everybody in our team had the same objectives. No, we had different views of injecting or smoking or stimulants versus opiates. Yeah, so as we went out from being people who used drugs and our team, we met all these health professionals. And as a very famous drug user activist called Jude Burns said, these people are trained to fear us. So we just have to try to be engaging, meeting people with a sincere and open heart, and hope that they can learn to overcome the fear that has been instilled in them about us. And the great GP, Dr. Chris Ford, that I was describing earlier, her greatest capacity was to love her patients in a professional, empathic way and acknowledge what she didn't know. And she said her biggest teachers were the very drug users that she was trying to care for and did care for so effectively. And I think that process of both sides recognizing that if we can work together, we can do something we can't do alone. In my local community, I have lots of drug users with local injecting injuries. I meet them running my secondary NSP, the needle and syringe program, where we give out needles and syringes through local drug suppliers and local drug users. And I see these injecting injuries, but I'm not a nurse or doctor. I don't know how to respond to them. So that's why we need professional partnerships, because peers can draw people into a system, but the professional system has its own intrinsic values, and we're not trying to dismiss that. We're trying to connect the two things together so the most marginalized have healthcare, housing, spiritual care, whatever the key issue is.
I totally agree with the professional part. We need professionals to be involved. There are a lot of content on the internet when you search about safer injecting, and there are myths. People will start talk about it and do it really badly. It could lead to injuries. And but my question about it, and I think this is comes from experience. When we talk to doctors, and the question is about drugs and how to effectively or correctly administer it, their oath in protecting life, they feel that it's contradictory in promoting harm reduction. How do you respond to that?
Yeah, look, I mean, for me, the process of harm reduction is where we start. So for 10 years, when HIV arrived among people who injected drugs, we had in Edinburgh in Scotland, they had been testing drug users for hepatitis B. They back tested and found that 50% of them had HIV. Now, initially in our country, this was the first information we had. The fear was that we could already be at this devastating level. It turned out that Edinburgh had a very poor policing strategy of restricting access to needles and syringes, and that had caused a unique outbreak in Edinburgh. But to start with, this jump from that you get from 10% to 50% very quickly in HIV rates, and in London we had 5%. So we were very worried that we would get to this level and then jump into this high level. And that really made us committed to trying to find responses that worked. Now, for the first 10 years, we didn't think about human rights. We didn't think about the wider issues. We were saving our lives. We were saving our peers' lives. We thought 50% of our friends could die. That's what we thought and knew. Luckily, antiretroviral treatment arrived and saved many, many of our friends. But for me, this beginning is harm reduction. The beginning is to start to fight for harm reduction. Once you're protecting your health, that brings with it an intrinsic sense of self-value. What we saw in the team I ran was that I ran two drug teams. One a more traditional health-based team that told people to stop taking drugs, and another which was run by drug users and the local general practitioners that said, we don't really care whether you use drugs. We want you to be healthy and to have a positive life. How could methadone help you in that journey? One of our probation officers worked across both teams, and she did a review with my permission and found that, in fact, the drug user-led team had twice the drug-free outcomes of the medical team. Because when you empower people, give them the chance to make their own choices, some of them chose, or in fact, more of them than the other group chose to be abstinent. However, other people lived very healthy lives on methadone. And I think it's about recognizing that sometimes if we push for these drug-free outcomes too hard, we actually make people much more resistant to change, and people actually stay where they are rather than change. I'm conscious we ought to show the video at some point as well.
Yes, we will. But let me just go back on, because I am glad that you mentioned human rights earlier, because that puts us in the context of human rights-based approach. And with that, there is a question that is a bit related to it. actually it's a lot related to it. With so much stigma against PWUDs or people who use drugs, most have internalized it to the extent that they wouldn't identify as PWUDs. They refuse to be organized. How do you overcome this as peers?
Look, I mean, there hasn't been a mass coming out of drug users in the UK. I mean, I came out 20 years ago on a TV documentary. No, the other drug users in that program spoke, but spoke with their faces covered. The consequence was for me was to lose my job in the health service and also to lose my consulting company because my main customer was the criminal justice service. So there are consequences for people to come out. And I think Carl Hart's work is inspiring in terms of getting people to think about, particularly people who are more empowered in more professional, in places which are more resilient, who can say, look, I'm a drug user. I'm someone who is identified. I think the more people that identify, and I hear people say that having heard me speak about my drug use, it made them much more comfortable to talk about their drug use. Realistically, I hope that then starts to change this internal stigma, that we don't have to have shame. Because one of my concerns is that shame actually makes what's called addiction far worse. If you are feeling shameful, I think it even increases your withdrawal symptoms, that because you bind the whole process up in shame and fear, it makes the experience worse. My experience personally of detoxing and other things is that when I feel empowered, I deal with that process much better. I think that's the message we need to get out. This is about saying, even if you don't want to tell other people you're a drug user, if you use your drugs from a place of shame, it changes your engagement in them. It changes your experience of those drugs. And if you have dependency issues, I think it makes them harder and deeper and more difficult to change. So I would say to other drug users, you don't have to all come out. But please, at least if you are choosing to use drugs, do it from a place of celebration and pleasure seeking or pain management or whatever it is. But don't do it immersed in shame, because it just undermines the experience and makes the negative consequences more likely and more hurtful.
You're getting a lot of hearts and applauses from the audience. Thank you. And I totally agree with that. And I always say that it says all about peers and community, and also on that. But when we're dealing with internalized stigma, it who will help you but your community members, your friends, your also yourself. There's a level of walls in there that your friends can help you break down and deal it with them. And that says a lot about your catchphrase: community works, peer works. And credits to TLF Share. I've said it in the video. Sarili at kaibigan ng tutulong. When it comes to stigma and discrimination, it's yourself and your friends. How have you encountered PWUDs who are unaware of their rights to health, safety, to justice? That's the first question. If yes, how were you able to familiarize them with their rights so that they become willing partners to harm reduction advocacies?
Yeah, look, an immediate story comes to mind when you ask that question. So thank you for that question, Mimi. I was very privileged to go to South Africa. It was just around the time when Nelson Mandela died, so I had the privilege of arriving in the country just after he died and seeing this country celebrate their great leader who had led them on such a journey of change and transformation. And yet at the same time, apartheid continued for many poor people, and the apartheid policing that had been sustained from that difficult time was really being targeted at these very poor drug users, often from black communities, but not exclusively from black communities. And I was in Cape Town, and look, I'm a drug user, and I was looking to try to buy some drugs. And one of the realities when you try to buy drugs in a foreign country is that you look for another drug user who can help broker you on that scene. And being a white rich drug user is not the best way to manage your security, so you use other people to help you. And I met these pair of brothers who were mixed race drug users, And they were hustling on the scene, and they quickly saw that I could be a way of hustling. And one of the things that I'm doing, partly to prevent people from robbing me, is also talking about the work I do and explaining what I do. And one of the brothers has gone on to be a drug user organizer, and he says, look, in that, I was there for a conference, and I arranged for them to get free passes to come into the conference. Then they got to meet lots of other South African activists and organizers. And there is a now wonderful South African network of people who use drugs, which I'm not claiming credit for in any way, but I'm being very privileged to work alongside them and see just how you can start to say to one drug user, you don't have to be ashamed about this. Your life might be tricky right now, but you don't have to live your life in shame. This is a political struggle. Don't see it just as a health struggle, but you have to sort your health out to fight for your politics. So let's manage these things together. And I still remember with fun dancing around with these guys, and just that sense of release, that sense of belief that I don't have to be like this. Now, do people immediately become super activists? Of course not. It takes training, it takes learning. You have to learn ethics, you have to move away from street hustles to working in solidarity. And this can take time, and some people may not do it right. And drug user organizing is complicated. So I don't want to sell you perfect stories, but inspiration happens all the time during this work, all the time.
Yes, we can commit mistakes along the way, but we'll figure it out when we get there. Whatever happens is the only thing that could happen. And I think this is the perfect time to play your video. But before we go on that, well, after the video, we'll get one more question from the audience. People, if you have a question, put it on our Q&A boxes. There is an upvote, so you can help us choose which is the perfect question for us to answer later. Take it away.
Peer work has been increasingly recognized as the most efficient model of intervention in harm reduction programs. Peer workers' expertise and engagement within the community is invaluable in delivering outreach and ensuring access to services.
Despite agreed language and recognition of peer work in international guidelines and reports, the reality is often much more challenging.
Partners in this space came together and facilitated a global community consultation of peer workers to talk about their daily realities and highlight areas for improvement. Community leaders organized 15 consultations among drug user and sex worker peer workers in 12 countries.
This led to a roundtable discussion of 75 people from 25 countries, including representatives of the UN, donors, public health specialists, programmers, and civil society, with peer workers at the heart of the discussion. The discussions were structured around the key themes identified in the consultations.
From these key themes, the following challenges were identified during the discussions. 1. Fostering self-organization. Programmers rely on the privileged access and lived experience of peer workers to reach and engage the communities in order to deliver services. But once the community is ready to self-organize, the initial implementing organizations should step back instead of competing for the often very scarce resources. If funding is scaled back, the community-led initiatives are always the first to be cut.
2. Career paths and employment conditions. Peer workers are the cornerstone of many programs, but they are often the least protected, recognized, and the most exposed to risks. Most don't have equal worker rights with salaried positions and benefits such as health insurance and social security. In many contexts, peer work is not recognized as a formal profession or in national health systems. Evolving professionally can be very difficult for peer workers, and they often reach a so-called glass ceiling, getting stuck with limited opportunities for career progression, reflecting the different value placed on lived and learned experience.
3. Safety and security. Peer workers often work with and come from criminalized communities with inherent risks of arrests, harassment, and exposure to violence. Peer workers can provide access even in remote or difficult to reach environments such as conflict zones, which leads to further contextual risks. Navigating within highly stigmatized communities comes with additional risks, such as being misunderstood or mistrusted by their peers and the wider community.
4. Meaningful participation. Peer workers are the most legitimate to speak as a representative of their own communities. Many policy-making spaces are often difficult to access, with bureaucratic and language barriers that can limit peer workers' meaningful involvement. To alleviate some of these challenges, 10 key recommendations were identified.
Peer workers must have the option to do more than just service provision. They should be encouraged and actively supported if they wish to self-organize and/or take on a representative role for the community.
Those working with peer workers should respect this journey and take great care to foster their independence, rather than misreading this as a threat and competing in this space.
Lived experience and privileged access should be recognized skills in job descriptions and human resource frameworks.
Peer workers should receive proper induction training and should be offered ongoing opportunities for career development and progression, including into other professions. Training priorities should be agreed in consultation with those delivering peer work.
Peer workers must receive fair remuneration that corresponds with their level of engagement and responsibilities. They should have the opportunity to progress towards the same benefits associated with a salaried position, such as health insurance and social security.
The inherent risks associated with peer work must be mitigated through proper training, protocols, and risk management. Organisations must have clear processes in place for supporting peer workers if they are injured or arrested.
When engaging in community work, we must build the capacity and sensitize other actors such as police, religious leaders, and health officials to create safer and more collaborative working environments.
The role of peer workers should be understood by all stakeholders, including within their drug-using or sex worker community.
Strong effort should be made to ensure peer workers have equitable access to local, national, regional, and international policy spaces. This should be facilitated by stakeholders at all levels.
To ensure meaningful participation, peer workers should receive training and capacity building according to their own level of knowledge and desire to engage.
I love it. I love that video. It's actually applicable to all the KPs that we mentioned earlier, not just for PWUDs, PWIDs. It's a game changer, I think, and it's a good guide not for only for communities that are starting to organize themselves, but it's a good guide for agencies, government agencies who want to engage communities and wants to empower them. Because as you mentioned earlier, that that's the global age strategy should be the 30% of the HIV response, which is peer work. That's really it's a good guide, and since it's uploaded on Facebook and YouTube, we're streaming live there. They could go back to it and reference it at later time. Let me go back to one of the questions, or just read a few of the reactions. PWUD working as community health workers or outreach workers were not paid that much, even saying that they'll only use it to buy drugs. Yes, and for that's actually a context for our we call it ayuda here. The help in the government's aid on people, and there have been accusations that people are using it to buy drugs, and they don't most don't want to cry discrimination because this would mean they'll out themselves as users and become vulnerable to arrest. Thank you, Attorney Tetay. Let me just read one from the Q&A. With so much, that on the top of the epidemic on HIV and a very traditional perspective of government and culture on drug use, how will we engage poor communities in the current context of the pandemic?
Yeah, look, I think the pandemic's been a very challenging time. It's pushed us back into our homes for those who have homes, and then those who don't have homes, I think, have really struggled much more. They've been, in some contexts, they've been offered additional support, which is really great. And in the UK, we've housed many of the people living on the streets, but we've also struggled to keep them housed because their lifestyles they're not tolerated within these hostels that try to set rules for people, which is often why people were on the street in the first place. So there's this challenge. On the other hand, drug user groups have really shown ourselves to be very, very important during the pandemic. We've helped keep needles and syringes going out to communities. Areas without drug user groups in the UK have seen a 25% drop in needle and syringe distribution. My area that has engaged drug users and drug suppliers has actually now gone from 28% coverage to close to 100% coverage. So I think we've been able to use this public health focused period to show people why drug user groups are able to respond. And also among recovery groups, there have been virtual systems used to carry on offering support groups, to carry on offering mutual aid. And I've seen some real creativity among the recovery part of our community. And I think the ability of us active drug users and the recovery community to see each other as one community that needs to speak with a more sympathetic mutual voice is a very important part of fighting for our rights. But I think giving our community the sense to come together, to receive services through drug user groups, I know in my area that's led to a strong sense of community among drug users because they've recognised that it's their community that stepped up during this pandemic, alongside our professional partners who give us the needles and syringes and naloxone to help our community.
Thank you. Let me just check if there are any other questions, or is there any community leaders or members here on our audience who would like to join us? You can use your raise hand function and chat with us. This is a great opportunity to be able to chat with Matt, who has been very engaged in our previous sessions in the past few days. Let me just give a quick recap of your video. I'm back again with my four great ideas that you could easily remember. Number 1 is self-organization. 2 is career paths and employment conditions. 3, safety and security. And lastly, and one of the most important, meaningful participation. It has to be a meaningful participation. And I think it says a lot about how we can create better connections and better relationships with our agencies, local agencies, not just NGOs and CSOs. We can also involve our religious sectors and DSWD, Department of Social Welfare and Development. When you mentioned employment conditions and career paths, I see that there's an opportunity for them to become social workers eventually, and that could be a paying job, and it empowers the community. It says a lot about how we do not discriminate our people, or do not stigmatize where they come from, or where they on their setting. We do not discriminate on their range of realities. And thank you for sharing that video. I guess we don't have any questions or on our event. What are your last words of message for our audience today, our community members and our partners?
Yeah, look, firstly, thank you very much for inviting me. It's a real privilege to come and take part in an event in a country that really is at the epicenter of the war on drugs right now. I think, I have huge respect for the work you're all doing and the bravery and courage that you're all showing. And brothers and sisters from the drug using community, please take care of yourself. I would recommend to you that you look at how you think about risk assessment, think about how you do your community in a work that supports yourself and supports your community, but doesn't put you at such undue risk that you risk taking yourself away from the community as a key resource. So think about this very, very strategically. This is not a time for reckless behaviour, but it is a time for community support. And just a last message, yes, I really believe in the ability of peer work to become a new key. I've said publicly that I think this could be a new golden age of peer work, but that requires us to do it in an ethical way. What I saw in my work in East London was, for someone who was a really street drug user, it took about a 5-year journey to go from being street drug users to doing a bit of low-level peer work, helping friends, to maybe starting to train as a volunteer, and then eventually becoming a paid relief worker in our service. We also saw that many of the people who volunteered for us didn't go on to work in the drugs field. They went on to train as social workers. They went on to, one case, run a sex club. Another one went on to train in health service. Others became security guards. They chose different paths. Peer work for people who are struggling with drug use can often be a way of reconnecting, re-engaging, and picking back to Andrew's discussion at the beginning. Yes, this process is therapeutic, it's motivational, but I think there is a strong relationship between personal self-motivation and community empowerment. When you stand within a community that feels strong, you gain strength from that. And then as you grow stronger and contribute to the community gets stronger and responds more to its members. And I think we've seen that in the gay community, and I've learned a lot from having friendship with that community. And I think the drug using community needs to celebrate its diversity, embrace our self-identity, look after ourselves and each other in these hard times, but never underestimate the potential of what we can achieve when we all work together.